Hello, everyone, dear friends and colleagues, and thanks again for being here with us in this course, in this 2 days course, Exploring Fetal Brain in our conference. And the topic of my 2 talks, actually, which I've combined together because essentially, actually, they deal with the same topic, which is anomalies of the corpus callosum. We will go through the different major anomalies, such as complete and partial agenesis of the corpus callosum, and also we will explore the less common condition which might potentially affect the corpus callosum and cavum septi pellucidi, such as the TNT corpus callosum, mypoplasia of the corpus callosum, pericallosal lipoma, large and thin cavum septi pellucidi. So let's start with the anatomy. So we know that the corpus callosum is the main commissure of the brain. It's essentially a bundle of billions of fiber, which essentially enable the connection between the 2 different hemispheres. So this is not the only cerebral hemisphere. We have other 2 minor ones, which are the anterior and the posterior commissure, but the corpus callosum is, of course, the largest commissure of the brain. Let's go to the imaging, and we know that essentially at least most of the guidelines, actually they do not recommend to directly visualize the corpus callosum, but just to identify the cavum septi pellucidi. We know that the cavum septi pellucidi is the anechoic, rectangular, or trapezoidal structure in the anterior part of the brain, which is just follows the hyperechogenic interhemispheric fissure. And of course, in this condition, can you see that this is close to the frontal lobes of the lateral ventricle? So why do we should look at? So we should assess, at least confirm the normality of the cavum septi pellucidi, because we know that the corpus callosum forms the roof of the 4 ventricles. So essentially, at least in the majority of cases, not all cases to be honest, when we see the cavum septi pellucidi, we can confidently say that the corpus callosum at least is roughly there. But if we look at the anatomy, of course, we see that when we approach the most anterior part of the brain, the so-called anterior complex, we actually can reach the diagnosis of most of the condition involving the corpus callosum and cavum septi pellucidi, just looking at the relationship between the different parts of the brain, at least in the anterior part of the brain itself. So we know that from the anterior to posterior part of the brain, we have the interhemispheric fissure. Then before the cavum septi pellucidi, we have this hyperechogenic line, which is perpendicular to the interhemispheric fissure, which is the callosal sulcus. Behind that, there is of course, the corpus callosum, and then the cavum septi pellucidi and the 2 frontal lobes. So essentially, in order to describe in more detail the cavum septi pellucidi, we have to confer that this is not just present, but that is rectangular or trapezoidal in shape, and that essentially what is also most important is that the frontal lobes are anechoic, and the medial part of the frontal lobes approach the box of the cavum septi pellucidi. And essentially, anatomically speaking, as you can see, the medial part of the frontal lobes is adjacent, but can be distinguished by the cavum septi pellucidi itself. And the normality of this condition actually ensures that in most of the cases, the supratentorial anatomy is normal. So this is a video clip, can you see? So this is the cavum septi pellucidi is anechoic, is rectangular or trapezoidal. We can see that the anechoic frontal lobes whose medial walls is adjacent but distinct from the cavum septi pellucidi. Why it is important, as I told you, that in most of the cases, most of the anomalies which involves the anomalies of the corpus callosum and cavum septi pellucidi actually gives an abnormal appearance on this ultrasound imaging of the anterior part of the fetal brain. When we look at the cavum septi pellucidi, we have to be very careful that, of course, if we slightly go from the cavum septi itself, we slightly go to the fornices, we see that the normal images of the corpus of the cavum septi pellucidi, which should be anechoic, rectangular, or trapezoidal in shape. If we go slightly down, sorry, just messing up. So can you see this is the cavum septi pellucidi? If we go slightly down towards the basal part of the brain, actually what we can identify is not the cavum septi pellucidi itself, but this structure which is composed by 3 different hyperechogenic lines. And we have to be very careful not to misdiagnose this as a cavum septi pellucidi, because it is not the cavum septi pellucidi, but this is actually a different structure which are called the columns or the fornices. Can you see this is the cavum septi here, and at some point we can see a structure which is very similar to the cavum septi pellucidi, but with with a hyperechogenic line in the middle part of it. So this is not a cavum septi, and we have to be very careful because in most of the cases of undiagnosed agenesis of the corpus callosum, actually the sonographer or the doctor just identify the fornices and not just the cavum septi pellucid itself. Of course, the only way we have to identify the corpus callosum is by obtaining a sagittal view of the fetal brain. The ultrasound probe should be oriented, the ultrasound beam, should be oriented through the sagittal to the anterior fontanelle or the sagittal suture, and in this case, you can see the corpus callosum, which is a comma-shaped structure, which is actually delineated by two hyperechogenic lines. So this is the cavum septi pellucidi. Can you see this structure is the third ventricle, and this hyperechogenic structure which forms the roof of the third ventricle is the chorioid plexus of the third ventricle itself. However, we cannot see from this image that the corpus callosum is entirely normal. And why is that? Because in order to ensure the normality of the anatomy of the corpus callosum, we should ideally look at the two most important parts of it, which are the antero-inferior part, which is the rostrum of the corpus callosum, and the postero-inferior part, which is the splenium, which has the part of the corpus callosum which commonly miss when we have partial agenesis. How can we identify that? Of course, we have to orientate the ultrasound beam perpendicular to the body of the corpus callosum itself. And of course, just get this picture. So can you see this is a magnified picture of the corpus callosum in which we can see the different parts. Can you see this part is the anterior inferior part, which is the rostrum, and this other one is the posterior inferior part, which is the splenium. It is important because at least in most of the cases in partial agenesis of the corpus callosum, we have the splenium which is missing. This is another example. So can you see, we have just not to identify the corpus callosum. We have to ensure that the anterior inferior and the posterior inferior part are present. We have to be sure that the corpus callosum is homogeneous in its thickness. And of course, the length of the corpus callosum, we will go through that, is of course appropriate for the gestational age. So in order to confer the normality of the corpus callosum, we should always identify these two parts of the organ. Should we measure the corpus callosum itself? This is very questionable because we know, at least a couple of systematic review and meta-analysis has shown that there is a great variability in the reported charts of fetal brain structure, and this is of course involved the cerebellar vermis and especially the corpus callosum. So can you see which is the most published chart of the corpus callosum actually differ as regards their methodological quality and also their different percentile. And of course, another issue, so should we use the color to identify the corpus callosum? And I know this is a very controversial question because in most of the cases, what we do in order to identify that the presence of the corpus callosum is actually apply the color Doppler or power Doppler. Sorry, I'm just still messing up with the slides. However, in order to look at the entire normality of the organ, using the color Doppler is not so. It's not just, I would not say it's appropriate. It's just not enough. Why? Because as I told you earlier, in order to be sure that the corpus callosum is present, we have to identify the anterior inferior part and the posterior inferior part. And if we look at the color Doppler, so this is the pericallosal artery which arises from the anterior cerebral artery. This actually does not entirely follow the anterior inferior part of the corpus callosum. So applying the color Doppler and identify the pericallosal artery is a good tool, of course, to confer that the corpus callosum is roughly there, but does not tell us that all the part of the corpus callosum are present, especially the anterior inferior part, and in lesser degree the posterior inferior part. And this is an example. We'll go through that. So during my case presentation, this is a case which was conferred to be after birth to be affected by partial agenesis of the corpus callosum. Can you see that in this case we can see the anterior cerebral artery, the pericallosal artery arising from the anterior cerebral artery, which follows the body of the corpus callosum. But if you look here, we cannot identify the splenium. So there is a missing splenium. And this is another example, of course. This is a normal case. So can you see, this is not useful to confer that the rostrum is present. It's more useful to confer the splenium is present. And why is that? Because the posterior inferior part of the pericallosal artery actually follows the the corpus callosum itself and delineates the splenium of the corpus callosum. So should we use Doppler? Yes, in order to roughly identify the corpus callosum. Should we use color Doppler in order to identify partial agenesis of the corpus callosum? This is very questionable. How can we complete our ultrasound assessment to confer the normality of the anterior complex of the corpus callosum? Just simply obtaining the coronal view of the fetal brain, which is actually the imaging view for which most of the radiology they do the diagnosis. What we can see in this imaging plane, we can see, of course, the interhemispheric fissure, the sulcus of the corpus callosum, of course, which is this hyperechogenic line, which is perpendicular to the interhemispheric fissure, the two anechoic frontal lobes, whose medial walls is close to the cavum septi pellucidi, but which can be distinguished from the cavum septi pellucidi itself. And also this structure, this hypoechoic structure, is the corpus callosum itself. So it is, of course, has a different appearance compared to what we can see on the sagittal view of the fetal brain. And in order to do that, so why this classification is important? Because if we look in details at the strict relationship which the different part of the brain has in the anterior part of the brain itself, we can actually confidently reach a diagnosis of callosal anomalies also starting for the actual view of the fetal brain. And which are these clinical questions? Of course, so the first three are very obvious, and the first is the calvarium normal, are the cerebral hemisphere symmetric, is the interhemispheric fissure present. The other one are specific to the anterior complex, cavum septi and corpus callosum, and are is the cavum septi pellucidi normal? And in order to define a cavum septi pellucidi as normal, it should be visible, rectangular, and anechoic. Are the frontal lobes adjacent to the cavum septi pellucidi? Is the third ventricle normal? Of course, these are the most common clinical questions which tell us whether the corpus callosum is normal or not. So let's go through the different clinical cases. Of course, this is the first one. We can see, of course, this is an actual view. As you can see, the cavum septi pellucidi is we cannot strictly identify that, but someone can actually misdiagnose this as this part of the brain. But if we look at the frontal lobe of the brain, we see that, of course, we cannot see the cavum septi pellucidi, but if we look at the frontal lobe of the brain, one is here, and the other one is there. So they are displaced from the frontal lobe. So let's look at another case. So we can see that, so we cannot see the cavum septi pellucidi. Also, this structure, which can be also misdiagnosed as a cavum septi pellucidi, is very difficult to misdiagnose as a cavum septi pellucidi because it's not rectangular, it's not anechoic, or trapezoidal in shape. But if we look at the anterior horns of the lateral ventricle, we see that one is here and the other one is here. So they are very displaced from the cavum, from what it should be the cavum septi pellucidi. And this imaging characteristic is typical of just one condition, which is the complete agenesis of the corpus callosum. So only the complete agenesis of the corpus callosum has this striking imaging sign, which is no visualization of the cavum septi pellucidi and a frontal lobe displaced from the midline. So can you see this is a normal picture? So normal case, cavum septi pellucidi, anechoic, rectangular, and the frontal lobe adjacent to the cavum septi pellucidi. In this example on the right, so we cannot strictly or completely identify a cavum septi. Also, it can be diagnosed as a cavum septi pellucidi, but as I told you, as something very obvious, the cavum septi should be always anechoic. But even in case we misdiagnose this as a cavum septi pellucidi, if we look at the frontal lobe, so can you see one is here and the other one is there, so they are displaced from the midlines. And this condition is typical of just one anomaly, which is complete agenesis of the corpus callosum, which the organ is completely missing. And why we have displacement of the frontal lobes? Because the bundle of fibers which cannot pass the midline in the middle part of the brain and forms the corpus callosum run parallel to the interhemispheric fissure and actually reach the other hemisphere on the anterior part of the brain. And doing that, they push laterally the two frontal lobes. So they are called the aberrant bundle of Probst. So can you see this is another magnified picture? So which are the main imaging feature of complete agenesis of the corpus callosum? On the axial plane, absent cavum septi, displaced frontal lobe, we can have sometimes colpocephaly, which is a tear-shaped appearance of the posterior ventricle. Sometimes we can have the third ventricle, which is actually higher. So the position of the third ventricle is higher than what should be. And course, we'll show you another case. The diagnosis is confirmed on the sagittal view of the fetal brain when we cannot see the common shape structure of the corpus callosum itself. Even in this case, should we apply the color Doppler and identify the pericallosal artery? Of course, we can do that. This is not essential for reaching the diagnosis because the diagnosis actually is done upon the lack of visualization of the corpus callosum. Also, we can suspect this in the axial plane of the fetal brain. So what can we see on the coronal view of the brain? Essentially what we see on the axial plane, we cannot see the cavum septi pellucidi, and we see that the frontal lobes are displaced laterally from the cavum septi itself because of the aberrant course of the bundle of Probst. And this is the diagnosis. So can you see? Just actually compare a normal case with an abnormal case. So visualization of the cavum septi and frontal lobes, no visualization of the cavum septi and displaced frontal lobes in the agenesis of the corpus callosum, direct visualization of the organ on the sagittal view, no visualization of the organ in the sagittal view, and of course the pericallosal artery, abnormal course of the pericallosal artery, which does not follow the entire length of the corpus callosum itself. And these are, of course, the resume of the old ultrasound signs. So what should we do in case of complete agenesis of corpus callosum? So should we go for karyotype? And the answer is yes, because the occurrence of standard chromosomal anomalies, common chromosomal anomalies, is about 5%. CNVs is about 6%, but also in case, even in case in which we have normal array and normal karyotype, the risk of having single gene disorder is high. This is a meta-analysis done by ASMA in which the authors reported that 32%, so perhaps it's very high, does not reflect my clinical experience, but it's very high occurrence of anomaly detected only at next generation sequences. So when we ask for genetic assessment, we should not go just for MRI, just for karyotype and array, and also ask for single gene disorders. Should we look for MRI? I don't want to jump into the diatribe between MRI and ultrasound because these two techniques should be complementary rather than opposite. And this is a meta-analysis we did together with several friends in which we reported that the additional yield of diagnosis so provided by MRI is about 11%. So in some cases, in a significant proportion of cases, MRI provides additional information, especially those conditions which are less easy to diagnose with ultrasound, which are anomaly of the cortical development. So should we go for MRI? And the answer is yes. And these results have been confirmed by a large collaboration study which involve almost 500 cases of agenesis, of complete agenesis of corpus callosum, in which you can see that the additional yield of MRI was 12%. So we should go for MRI itself, at least in complete and partial agenesis of the corpus callosum. So MRI is particularly useful when the mother, of course, is big, where the BMI increase. So especially in this condition, we have to go for this complementary imaging assessment. The most important question is, how is the outcome of baby with isolated anomalies? So we know that, as I was mentioning earlier, that corpus callosum anomalies, that the agenesis of the corpus callosum can be associated with genetic anomaly, with additional anomalies detected at MRI, with additional anomalies detected at birth. But even in case when the anomaly is isolated, 75% have a normal outcome. Of course, these data refer to papers published not so recently. 15% of them have borderline to moderate adverse neurodevelopmental outcome, and in about 8% of cases there was severe neurodevelopmental outcome. Regarding the different neurodevelopmental ability, in 11% of cases we have anomaly on the fine motor control. In 15% of cases, anomaly of the cognitive status, anomaly of the coordination is up to 10% of cases, and language anomaly in 8% of the cases. So in most of the cases of isolated anomaly, the outcome is roughly good, but what we have to tell to parents is that it is not possible to completely define an agenesis of the corpus callosum as isolated before birth, especially at the time of diagnosis during the second trimester of pregnancy. Let's have a look at another case. So in this case, we can see, of course, let's try to apply this algorithm we mentioned earlier. So in this case, we have, of course, an actual view of the fetal brain. We can see the cavum septi pellucidi. So the cavum septi pellucidi is present. We can see the frontal lobes. The frontal lobes are, the medial part of the frontal lobe is adjacent to the cavum septi pellucidi, and the cavum septi pellucidi itself is anechoic. But if we look at this shape, it's not rectangular or trapezoidal in shape. So in this condition, when we have a square appearance of the cavum septi pellucidi, we should always go to neurosonography, because it might be, I would say, one of the few, I would say the only signs of another condition called partial agenesis of the corpus callosum. In this condition, of course, part of the organ is missing, especially the posterior inferior part. So can you see in this case, we can see the anterior inferior part of the corpus callosum, which is the rostrum, but here the posterior inferior part is not present, and actually the curse of the organ should be like that. So in this case, we have missing of the posterior inferior part of the corpus callosum. This was a case in which the corpus callosum measured 14 millimeters, so it's very short, also considering the high variability in the reported charts. Let's have a look at the other picture. So we can see the rostrum here. In order to look at the splenium, we should orientate the ultrasound beam parallel to the posterior inferior part of the corpus callosum itself. Can you see the rostrum is present, but we cannot see the posterior inferior part, which is the splenium. So this is a condition called partial agenesis of the corpus callosum, and this imaging appearance is the most common one we can encounter in clinical practice. This is another case, because can you see? It's easily to recognize the rostrum. It's very difficult to recognize the splenium, because the splenium is, of course, not there. And also, I was mentioning the application of color Doppler. Can you see the color Doppler looks entirely normal? And why is that? Because if you apply the color Doppler, it can roughly tell us that the corpus callosum is present, but it's not so informative regarding the presence of the anterior inferior and posterior inferior part of the brain itself. And this is another example compared to the normality. So just to resume, the imaging sign of partial agenesis of the corpus callosum, of course, is different compared to what we can see in the complete agenesis. The only signs at the actual view of the fetal brain may be of course, the square-shaped the square-shaped cavum septi pellucidi compared to the rectangular shape of normal cases. So, of course, in cases with the absence of the corpus callosum, the cavum septi pellucidi is not visible. Should we go for MRI? Of course, also in these cases, I would say yes, because these are the results from the multinational court of anomalies of different countries in Europe and Canada, if I remember well, in which we reported that the additional yield of MRI is about 12%. So we should go for MRI. We should also, of course, also go for genetic. What is the neurodevelopmental outcome of fetuses of children with isolated partial agenesis of the corpus callosum diagnosed before birth is roughly similar to what has been reported for complete agenesis. Of course, can you look at the number? Very few number of cases, because in most of them there was additional anomalies so detected only after birth or at fetal MRI. So in 7% of cases, the outcome is good. In 15% of cases, there is borderline to moderate adverse neurodevelopmental outcome. In 13% of cases, there is severe neurodevelopmental outcome. Do we have other signs to identify fetuses with partial agenesis of the corpus callosum, which is a condition which is very difficult to diagnose, especially because this baby, they do not have striking ultrasound sign, and this is a sign reported by Professor Chawi, in which he looked at the distance between the anterior cerebral artery and the choroid plexus of the third ventricle. The choroid plexus of the third ventricle is this hyperechogenic structure which forms the roof of the third ventricle itself, and in normal cases, actually, if I remember well, at 20 weeks of gestation, he measured the mean distance of about 10 millimeters, which was very short in cases of partial agenesis of the corpus callosum. How can we identify the choroid plexus? This is an example. You have to get a sagittal view of the fetal brain, and this hyperechogenic structure is the choroid plexus of the third ventricle. And these are pictures from the study of Professor Chawi. So can you see in this case this is normal. In this case of partial agenesis, the corpus callosum was here. The distance between the choroid plexus and the anterior cerebral artery was shorter than normal. In this case, of course, the authors did not provide diagnostic accuracy, the figures for diagnostic accuracy, of course, because they are study which included very few cases. And this is another study we did in order to look for other signs which can increase increase the diagnostic accuracy of ultrasound in detecting partial agenesis of the corpus callosum, which is the distance between the choroid plexus of the third ventricle, which is this structure here, and the splenio, or the distal part of the corpus callosum. So in normal cases, can you see that the most prominent part of the choroid plexus actually is before the splenium of the corpus callosum. In cases with partial agenesis of the corpus callosum, the most apical part of the choroid plexus actually is coincident with the distal part of the corpus callosum itself. Also, all these cases show a very short corpus callosum. This is another anatomical landmarks we can use to suspect these fetuses. Let's go and see another cases. So in this case, we have, of course, also starting from the axial view, we can have a anechoic round structure in the anterior part. Of course, in most of the cases, it's easy to recognize this as an arachnoid cyst. And we might say that in most of the cases, an arachnoid cyst of the brain is a benign condition with a reduced risk of neurodevelopmental outcome. But, and of course, it's not possible to look at the cavum septi pellucidi in this imaging view. But if we look at the frontal lobes, so can you see one is here and the other one is, just a second, is there. They are not close to what it should be the cavum septi pellucidi, but they are displaced from the midlines. And as I told you earlier, there is just one condition in which the frontal lobes are displaced from the midline, and this is the complete agenesis of the corpus callosum. So in this case, this was not just arachnoid cyst, but because the frontal lobes were displaced from the cavum septi, from the so-called cavum septi pellucidi, this is a condition in which there is a complete agenesis of the corpus callosum plus arachnoid cyst, and we know that arachnoid cyst may be part of the developmental spectrum of callosal anomalies. This is, of course, another. I don't know whether the video works. Yes, it is. It works. Can you see? We cannot see the corpus callosum on the sagittal view, and we just see the arachnoid cyst. How can we show that we are in the sagittal view? Because we could see at some point the cerebellar vermis. I'll show you another picture. Because you cannot see the anterior cerebral, the middle cerebral artery and the pericallosal artery, which follows the length of the corpus callosum. As can you see, this is another case, very similar case, different case, but a very similar one, in which, of course, there is the arachnoid cyst, but we cannot see the corpus callosum. So when we see an arachnoid cyst in the anterior part of the brain, especially when the frontal lobes are displaced, this is a striking sign of complete agenesis of the corpus callosum. And these are, of course, the other images on the coronal view. Can you see the displacement of the frontal lobes? This is a 3D. Of course, you can see the arachnoid cyst. You see also this convolution of the cortical surface of the brain, which is a common sign in fetuses with agenesis of the corpus callosum. Let's go and see another case. So in this case, what we have is that, of course, we have the cavum septi pellucidi is present. The frontal lobes are adjacent to the cavum septi pellucidi. Let's see again. The cavum septi pellucidi is rectangular, is anechoic shape, so apparently everything is normal. But this was a case referred, because I don't know why, the local doctor looked at the corpus callosum and it actually identified a short corpus callosum. So at the beginning of my presentation, I said that we should not measure the corpus callosum, and it is true because we have a great variability. But what should we do when we face a case like that? So in this case, can you see, we could see the rostrum. We also could see the splenium. I will show you another picture. So you can see the rostrum is this part of the corpus callosum, and this is the splenium, is this part. So when we have a small than normal corpus callosum, in this case, the corpus callosum was measuring 40 or 50 millimeters at 21 weeks. When the thickness of the corpus callosum is homogeneous, of course, even in this case, the pericallosal artery is normal, but we also gone through that and says that the pericallosal artery is not so vital in order to do this diagnosis. In this condition, we might say that the corpus callosum is hypoplastic. And what is the outcome of this condition is very difficult to say, because actually most of the cases which were labeled as hypoplastic corpus callosum before birth were actually discovered to be partial agenesis of the anomalies. This is a systematic review of the published studies which we did together with several experts in neurosonography, and we reported that also the burden of genetic anomalies was low. Abnormal neurodevelopmental outcome was reported in 75% of cases, but I was very suspicious that in most of these cases there were actually not just hypoplastic corpus callosum, but rather partial agenetic corpus callosum itself. But at least this is the most recent evidence on this case, on this topic. Let's go to another case. In this case, we have the cavum septi pellucid is present. We have the frontal horse. The medial part of the frontal horse is adjacent to the cavum septi, but it can be distinguished from the cavum septi. The cavum septi is rectangular or trapezoidal. Yes. Is this anechoic? The answer is no. And in this case, of course, what should we do? Is this normal? Also, in this case, we have to go and obtain coronal and sagittal view. So we should do neurosonography. And when everything, we see that the cavum septi pellucid is slightly hyperechogenic, the corpus callosum is present, the relationship between the cavum septi and the frontal horn is normal. This condition can be labeled, this is a very recently defined condition, as interrupted or obliterated cavum septi pellucidi. The evidence about this condition is very poor. There are very few studies which reported a, I would say, incredibly high rate of associated anomaly, abnormal neurodevelopmental outcomes in 6 to 7% of cases. Apparently, this condition is associated with a very low risk of genetic anomalies, and we also actually go through these anomalies in our meta-analysis. Can you see how few cases we have? And the risk of genetic anomalies was very negligible. In 65 to 70% of cases, there was normal appearance of the cavum septi pellucid in the third trimester, and the neurodevelopmental outcome was normal in about 90% of cases. Again, these are data from a meta-analysis. Our clinical experience, we see 15 to 20% of 220 of these cases, and in most of the cases, neurodevelopmental outcome was normal. But still, because in the published literature, it is reported a high rate, a relatively high rate of having cortical anomalies, a third trimester scan, and perhaps ultrasound, perhaps MRI assessment should be obtained. Let's go and see another case. I almost done. So we can see, even in this case, the cavum septi pellucid is present, is rectangular. The frontal lobes are present, are anechoic, are adjacent to the cavum septi pellucid. But if we can see, the cavum septi pellucid is also hyperechogenic in this image. We go to sagittal view. Can you see? We can see that there is a really strange mass in the anterior part of the corpus callosum, and the corpus callosum present with a different thickness in its length. And this condition was associated with a cortical anomaly, and this is called the agenesis of the corpus callosum, in which the thickness of the corpus callosum is completely dishomogeneous, and this was associated with an hamartoma of the corpus callosum itself. Very similar cases, which almost more or less looks the same. Frontal lobes are present, the cavum septi is present, is still hyperechogenic. And when we go to the sagittal view of the brain, so can you see, we can see that the very short corpus callosum, the rostrum is here, we cannot identify the splenium, and the corpus callosum is very, very thick. In this case, of course, we can apply the color Doppler. It's not so useful, as I already stressed. It's a personal opinion. And this is a coronal view of the same organ. What is this condition? Is the T corpus callosum. So T corpus callosum in the beginning, so the first cases of T corpus callosum were published about 20 years ago, and in most of the cases it was considered until now it was considered a very bad condition associated with increased risk of having genetic disorder, cortical anomalies, and associated brain anomalies. But when it is present in isolation and the length of the corpus callosum is normal, and we can identify the rostrum and the splenium, the outcome might be more favorable than what we think. This is the data from the meta-analysis. Can you see that we recently published? It's very few cases, so only 14 cases of condition labeled as isolated, and the outcome is generally favorable. So what should we do in this case? We should go for neurosonography, offer genetic testing, do neurosonography, late neurosonography for MRI in order to detect cortical anomalies, because the risk of having associated anomalies is high. When there is the rostrum and the splenium are present, and there are no associated anomaly, either genetic or structure, the outcome is likely to be good. Let's see another case, which is actually the opposite. In this case, we see that the corpus callosum is very thin, is measured less than 1 millimeters, and of course, it is a condition labeled as thin corpus callosum, also a very rare anomaly. I would not call it anomaly because the evidence is so poor to define it as an anomaly, especially when it's present in isolation. And as you can see, the neurodevelopmental outcome, there are only 3 cases of this condition present in isolation. So we do not actually how many cases we do not identify before birth. So in case of very thin corpus callosum, also we have to go for neurosonography, fetal MRI in case the neurosonography service is not as performant as MRI, and the outcome is very difficult to predict because of the very few cases so reported in the published literature. Another case, so in this case, is a direct assessment cannot be identified using the actual view of the brain. So can you see we have the corpus callosum is present, the thickness of the corpus callosum is present. We can see the rostrum is here, the splenium is there, but we have a homogeneous hyperechogenic mass around the corpus callosum itself. So what is this condition? Of course, it's not color Doppler. As you can see, and this is an anomaly called lipoma of the corpus callosum. Also in the past, lipoma of the corpus callosum was considered a very bad anomaly associated with epilepsy, cortical anomalies, and adverse neurodevelopmental outcome. But when we have this in isolation, the outcome is, of course, most of the cases is good, with the very low cases of genetic anomalies, especially at standard karyotype, chromosomal microarray, and also the number are very small single gene analysis. So what should we do in this condition? Of course, look for other associated anomaly. So doing invasive procedure is very questionable because of the very few number of cases published on this topic. But even so, in case this condition is isolated, the outcome is likely to be good. This is another case, the last one. What should we do in this case? Of course, the cavum septi pellucidi is present. The frontal lobes are present. They are adjacent but distinct from the cavum septi, but the cavum septi is very big. In this case, it was measuring almost 9 millimeters. So we know that the mean length of the mean lateral, so the mean lateral diameter of the cavum septi pellucidi is about 5. So what should we do in this case? Also, we should go for neurosonography, but in most of the cases, if the cavum septi pellucidi is large and there is no other associated anomalies, the outcome is likely to be good. Also, it is actually based upon a very few number of cases. And this is the same as very thin cavum septi pellucidi. Also, most of the cases in which we see a thin cavum septi pellucidi, it is because we have severe ventriculomegaly. When we do not have severe ventriculomegaly, of course, the evidence is very poor. Of course, most of the cases actually present in association with other anomaly, especially those involving the cortical surface of the brain. So at the moment, there is a very poor evidence to define a thin cavum septi pellucidi in our clinical experience, especially if there is nothing associated, the outcome is likely to be good. And I hope to not have bored you, and thank you again for being with us today.